Welcome, everybody. We'll try to get through this information in about a half an hour, 20 minutes hopefully, and then we can go ahead and answer some questions for you. Today what we really want to do is just take a few minutes to talk to you about I-10 and understand that there are interdependencies. Some people think it's just a coding problem, some people think it's a finance problem, but we want to point out a few of the interdependencies that you have. I want to bring forward a few of the activities that you could do. Everything that I'm going to be talking about today is on goal setting, and then after you have goal setting, you have activities to get you to your milestones. And then we do also have some suggestions for you to actually monitor yourself, your success, and make sure that you can get on the right path. So first off, when I talk about interdependencies, what we have to understand is ICD-10 as a coding system is not just for reimbursement. It is based on documentation. Documentation drives everything that we do, and documentation will generate data and the information that we absolutely use for patient care and quality care. So it's not just a reimbursement system. What I want to get across is that this is a scary time for quite a few people. Change is always very, very scary. And what we want to do is we want to actually build confidence within your institution, across your employee base. And I've just listed a few of the things here that when I talk about building confidence, this is what it means to me. First off, from a standpoint of the electronic health record or the medical record you're using, you want to make sure that you have confidence that all of the information is going to be in your medical record. It is going to be brought to the appropriate place. It is going to be put in there and authored. And you want to make sure that when you have a clinical documentation improvement program, that your CDI staff is very, very educated in the standpoint of how to talk to physicians, what to look for in the medical record, what comorbidities, complications. So we want to make sure that they know the most that they can get out of the medical record. You want your coders to have confidence. You want your coders to be able to read a medical record and say, I know what's normal and I know what's abnormal, so I know where to ask the questions, because that information doesn't just pop out at you. You really have to understand what's normal to recognize what's abnormal. You want coders to understand what they can use in the medical record, what information might key them into query, what other information do they not need to query that they can use for specificity. And you want them to make sure that they're confident in being able to assign the appropriate diagnosis code or procedure code. You want to have confidence in the finance standpoint that your claims are going to be submitted appropriately, that they're very, very compliant, that you don't have any fraud and abuse worries, that your codes that are being submitted are supported by documentation and medical necessity. You want the confidence in the quality of data that you're gathering. And the last one is what we're really going to talk about today. You want to have confidence in the transition plan that your organization is putting in play. How do we build the confidence? Well, here's a step-by-step method. First off, you need to understand your landscape. You need to understand what is today all about in your organization. What do you do good? What do you have challenges with? Where are you struggling, and where do you need the most help, and where can you maybe help someone else along? So after you know what your current landscape is, then you have to define your goals. And I put in here ideal versus acceptable. We all would love to say that we want 100% education, we want productivity at 98%, we have accuracy at 98%. We want all of that, but honestly, you have to sit back and realistically say, what do we think that we could really attain from a timing and a milestone standpoint for transition? Next is to allocate resources. We have to recognize that you're not just going to be putting dollars into this. You're going to be changing your systems. You're going to be having people power, as well as the EHR and getting the information to work together. And then you have to have an excellent communication plan, because this again is very, very scary. It affects everyone in the hospital, and so you want to make sure that you communicate very, very clearly what I-10 is, what it means to the different stakeholders, why they should be concerned, and what's going to be asked of them. And then the final is to engage those stakeholders. You don't want to go into your organization and just say, you have to do this. We're mandated to do this. You want to get engagement on your stakeholders. You want to make sure that people look at it as a team. Colin Powell once said, I love this, there are no secrets to success. It's a result of preparation, hard work, and learning from failure. And that is so very, very true. We're never going to be perfect in what we do. We can set our goals. We might change some of the goals, but I think the biggest thing to do is learn from what your mistakes are. If you learn and you go forward, you're doing so much better. So, what are some of the ways that we use the coded data and the information from the coded data? I really think it's important for an organization to understand that when we talk about I-10 and they think about coding and, oh, I don't use codes or whatever, almost anyone that works in an organization is touched by either the codes themselves or the information that is derived from the codes. And so I'm going to take a couple minutes here just to speak to some of the major areas that are affected. Number one, if you're in finance, you know right now that our hospitals are being looked at for the readmission rates. They're trying to do everything they can to make sure that patients are compliant with treatment. So what does our documentation do, and what does the I-10 code do when it's reported in? It will demonstrate medical necessity that supports and justifies an inpatient admission, any readmission, or continued stay. The specificity of ICD-10 will allow people to understand when a new injury has occurred, when an old injury has occurred, when a complication has occurred. It's great and wonderful because the longitudinal care of that patient can actually be evaluated. Number two, assist with standardized protocols. This is important. There's a lot of doctors that we try to talk to them about their compliance with their documentation requirements. They don't want to hear about I-10. I don't code, I'm not worried about that, but they are really concerned. So if you can get across that I-10 and documentation will help them understand the common complications, adverse reactions, comorbidities, and associated diseases with what they admit patients for. Again, this all goes to the specificity of I-10. It can provide all of that information. It can absolutely help us monitor what works well, what doesn't work well, and what the outcomes of patient care are. Third, standardized health information exchange. We're all hearing about it now. We know that healthcare is in a really tough situation right now. We want to make sure that we can communicate information across the country. No matter where you're going to be, you want to be able to have good healthcare, and I-10 will help standardize that communication. Of course, payment. Some of you might think payment should be number one, because if your hospital is not viable, then you're not going to be here and you don't care about healthcare. But payment is, depending on who your audience is, payment is a very, very important part of I-10, and also not as important as quality to others. So first off, our ICD-10 codes will drive our MSDRG payment system. And I put in here APC's fee-for-service because I-10 is not the only coding system. We have ICD-10-CM, we have ICD-10-PCS, and we have CPT. And it's used, there are different coding systems that are used in different situations by place of service and type of service and the provider of service. And so we have to compile these codes together. We have to recognize that we have to get smarter. The documentation has to support what the physician did as well as what the hospital says the physician did. And if they're not matching, then we're going to have some issues with payment. ICD-10 is used a lot for comparison, peer-to-peer comparison for physician to physician and hospital to hospital, and we call that the performance. And absolutely, as we go more and more into meaningful use, we have a lot more indicators for the quality of care and the performance measures for both hospitals and physicians. I-10 also helps to provide information for forecasting and public profiling, and we call this the public health arena, because this is information that whenever it's coded, it is reported to CMS. The CDC tracks, CMS tracks, we have the disease profiling. This is where we find out treatments that are used with diagnosis, what works well, what people have complications and why they have complications. Certainly your facility uses I-10 for budgeting and strategic planning. For compensation, there are many areas that use codes and the types of services or the diseases that the physicians care for, the severity of illness of their patients to actually reimburse the physicians, and also is used in research. So your main organizational goals when we're talking about the implementation of I-10, we want to make sure that there is appropriate education. We want to decrease any compliance risks that we might have. We want to have minimal financial impact as we transition to the new system. And we want to improve all the data quality for all those reasons that we just said we used. So from the standpoint of reaching goals, I'm going to talk about those areas, and then I'm going to say this is a common goal for them, and then give some suggestions about actions and action plans. So from an education standpoint, what do you have to do? Your common goal is to identify your stakeholders, and by stakeholders I just mean who is affected, who either is going to have something happen with them or what they do or how they do their job. You have to understand that one of the goals is to do a workforce gap analysis to understand where your strengths and your weaknesses are. And you need to plan for short-term and long-term educational needs. And so what are the activities under this first evaluation phase? Okay, when you look at your jobs are changing. I know that you've been implementing the EHR. Well, workforce has changed. There's a lot of jobs that have gone away. There's a lot of jobs that are being reorganized. There is anticipated to be a 25% increased need for coders in the future. And additionally, with like computer-assisted coding and other encoders are getting a lot smarter too, what people are starting to do is see that they have to focus on an auditing aspect instead of an actual straightforward coding aspect. So the type of job that's going to be done, as well as who's going to do it, will be affected. You want to determine your desired and current standards. And by that I mean, as an institution, you need to try to agree on productivity standards, accuracy standards. You have to understand what milestones you want to set, and then you need to measure against those to make sure that as you're implementing any of your education or training, that your people will absolutely meet those standards. If not, then you know when remedial training is needed. Please correct your deficiencies now. There are some people I've talked to that said, well, you know, we have to train in a new system, so we're going to just go ahead and train in ICD-10 and we're not going to worry about what today is. Well, I'll tell you, ICD-10, you have to feel good about ICD-9 and understand how the guidelines work and how the coding works, or you're not going to be able to get into ICD-10. So please think about what your landscape is today and correct any deficiencies today. Your timing and outcomes. Okay. Take a look at how many staff that you have. Take a look at how much time you will be able to allow your staff to get brought up to speed. Take a look at the quality of your work of your staff right now, and then figure out however many hours that you can have, when you want your certain milestones set, and then work backwards. And that's going to tell you when you should be starting your education. If you've got brand new people that really need to know a lot more health sciences education before they go into the coding or the documentation, the CDI, then you're going to have to start that education earlier and take those hours into account. You also want to figure out how you're going to judge your staff against each other to make sure that they're very consistent and they're all getting the same message, whether they're going to be a pass, fail, incomplete, or if they have to actually have a certain percentage proficiency rate. And make sure that if those milestones are not met, don't wait till the end. Don't say, okay, I'm going to give all of this education out, and then 2 months or 1 month before October 1st, then all of a sudden you find out that your staff isn't doing as well as you hoped. That's why you set milestones. You look at them, you trend them, and you make sure that people are doing what you anticipate. When we talk about data quality, we're talking about clinical documentation improvement programs. We're talking about auditing and making sure that the medical necessity is documented in the record. We're talking about data quality to ensure that any of the conversions of our database are appropriate, that when because ICD-9 and ICD-10 are not a one-to-one match, you're going to have to do conversions, and you're going to have to make sure that when your database and your reporting conversions take place, that you have good quality data and you're not just guessing. So some of the activities, if you're talking about a CDI program, some of the things that you can do is you can right now measure your query and response rate. How many times do you have to ask your physicians for some information? And how many times do they actually respond to you? And how many times when they respond to you do you actually get more money or a change in DRG? Really monitor that very, very closely. If you're going to get a change in a DRG, remember there's a lot of CCs and MCCs that are not going to affect payment anymore. So really get a handle on that landscape today. Make sure that you know where your severity is identified, and then do that conversion over to I-10 and see if that's still going to take place in the future. And then you want to identify those at-risk providers. Just like you identify your at-risk coders, at-risk CDI people, you want to make sure and identify those physicians that really need a little bit more help. They might be the best doctors in the world, but if that documentation doesn't provide enough information to be coded and reported, then they are going to be compared to their peers, and they're going to look like they're not doing as well as their peers. It's going to affect the hospital. So make sure that you talk with your at-risk providers and work with them early on. Audits and benchmarking. What we want to do, again, from the landscape now, moving forward, we want to identify those areas that we have inaccurate coding. So please start early. Whether or not you're starting education, the thing that you need to do is start with those audits. Make sure that you know how well your documentation is, how it's going to stand up to medical necessity scrutiny, and make sure that you understand where your coding challenges are going to lie. Your remediation now, it's really, really helpful to have auditors and do your audits so that they do it in I-9 and ICD-10, CM, and PCS as well. Because when you're coding something in both scenarios, you might not have a problem when you're coding an ICD-9 right now. You might have enough information to do what you need to do, but you need to do that dual coding, because you might find out that you could land into a much different DRG in the future if you don't have more specificity than you're using right now. When you're talking about compliance, and what do we mean by compliance? Compliance is the medical necessity. The medical necessity for anything that we do has to be incorporated. We not say that we have to write a book on anything, but we have to make sure that our documentation is comprehensive and that it does justify that admission. If someone has a length of stay longer than they normally do, we want to make sure that that documentation describes the situation, what is happening with that patient. If they're not responding, we need to make sure we understand why they're not responding to treatment. We have to ensure that the people that need to have the appropriate education with the payers to make sure that they follow the guidelines for the payers. CMS is not the only payer. Medicare is not the only payer. You've got Medicare and Medicaid, you've got all the private payers, and they all have their own requirements and regulations. So now is the time to start understanding the landscape of your payers. Find out, are they going to be status quo for a while and wait and do analytics afterwards? Are they going to expect to have dual coding and have information sent together? It's very, very important not to forget to talk to your payers. So what are some of the activities in the transition? Okay, you're first off, you want to benchmark against your peers. Whenever it's possible, you need to evaluate what your peers are doing, whether it's peer-to-peer for physician, peer-to-peer for hospitals. You have to understand where you stand. How many times do you admit someone and then readmit them? How many times do you admit people with complications? How many times do you extend the length of stay? Those are all going to be indicators that you need to delve a little bit deeper and find out if there's something that you need to remediate. Another thing to do is look at your RAC audits and your RAC conditions. Absolutely identify where those issues are. Not every hospital has the same rack issue. And so certainly some feel like they have everything under control. Don't look at just the top DRGs that you're looking at. You need to make sure from a compliance standpoint, you are confident in those high risk areas. And that's going to get you the MCC rates, the CC rates, the rack rates, the certs. Those are all going to give you that information that you need to go forward. Number two is I italicize the word consistent, and I think that sometimes we overlook this. When I talk about setting milestones and then measuring how well your staff does, a good part of that is to ensure consistency among your staff, not only within your hospital or hospital system, but when I remember when I used to work for a large healthcare system, I ended up finding that if not all of my staff was at the same level, then if we would report some claims and have an issue with how something was identified or coded, I might have 5 people that do it right, but if I had one person do it wrong, they would still come in and take a look at that and evaluate it. So you want to make sure you're consistently educating all your staff at the same time. Other things to look at from a compliance standpoint, reporting scorecards and coverage change policies. So in summary, what's the takeaway? First off, take your time to plan. If you don't have good implementation plans, if you just think, oh, I can wait till next year, it's, October 2014 is a long way from now, that's not going to work it. You need to take time, be methodical, stay on track with your plan. How do you do that? You have your milestones, and you make sure that you measure those milestones and trend them. If you don't meet some, then all that tells you is that you've been smart enough to recognize that you have to do some modification. Monitor the activities, use analytics. Please don't think that only one way is the right way. There are a lot of different reports. We didn't have much time today, so we touched on just a few of the reporting capabilities. Put all of that information together. Engage your employees and communicate your goals so people really know the pathway that you're going to be taking. Any questions? Yes.
This is very helpful, thank you. Great, almost like a checklist to go down.
Thank you.
How do we get a hold of the slides? How do we... Sorry?
Give me a monitor to make sure you get.
Perfect, thank you.
RAC, recovery audit contractors, that's one of the types of audits that are coming in now. To be honest with you, there's so much money in the government. There have been billions of dollars found over the last few years in fraud and abuse. So the government is putting a lot of money to fraud and abuse. Yes.
Hi, you mentioned about communicating with the staff and that
Yes.
there's a lot of nervousness around ICD-10.
Absolutely.
I completely agree with you. My question prior to that would be, do you feel like the hospitals, if you in a hospital environment, the hospital staff or the revenue cycle staff or even the HIM staff understands the depth of the impact?
You know what? I don't really think so. There are a lot of people that have had implementation teams put into play, and the biggest thing to do is to make sure that people that participate on the implementation teams are very representative of the staff within your hospital. But I think the finance people are getting nervous because they're hearing something about OI-10, but I know that in our education we have some orientation and overview education, because I think it's really important to say to everyone that's involved, okay, what does it mean? What is coding? And that's why when I went through those a few things, it's not just for finance, or it's not just for one thing. But I think it's also very, very important to tell them what it is, how it's going to affect different people. So managers might be looking at a brand new report, and they might have to say, oh my gosh, I got this data last year, I get this data this year, what does it mean together? If I used to get one code for a procedure, now I get 3. Are we doing 3 times the procedures, seeing 3 times the patients? What does that mean? So whether you're PFS or whether you're managers or whether you're physicians, everybody has to have an understanding of what it is, what it means to me, how is it going to affect my job, and what activities am I going to have to change.
Thank you.
Sure. Anything else? Thank you, everyone.
Thank you.